Dr. Elizabeth Ford is a graduate from the Universities of Oxford and Sussex, Research Fellow and now Senior Lecturer at Brighton Sussex Medical School. She has dedicated her life into research to improve the lives of those treated for rheumatoid arthritis, depression, anxiety and dementia. Today she'll be discussing pertinent ethical questions around the use of NHS patient data and how it is being utilised in the fight against COVID-19.
Hi everyone, my name is Dr. Liz Ford and I'm a Senior Lecturer in Primary Care Research at Brighton Sussex Medical School. Brighton Sussex Medical School is a fairly new medical school which took its first cohort of students in 2003 and it's jointly owned by both universities of Brighton and Sussex. My research in primary care uses electronic patient records from general practitioners to understand more about dementia and mental health, and I also do a lot of community-based research and public engagement around the use of patient data. Today I'm going to be talking about patient data, namely patient data from the NHS and how it is used in research. My talk will have three parts. Firstly, I'll describe to you what NHS patient data looks like. And second, I'll give you a quick outline of a case study of how we use patient data at BSMS. And third, I want to talk to you a little bit about how patient data is contributing to the fight against COVID-19, the current pandemic. First, a disclaimer. I'm a great believer in this phrase, data saves lives. And although there is some controversy, some members of the public have mixed feelings about their data being extracted and used for research. I think if we can do this in a way that is trustworthy and transparent, using NHS patient data for research will contribute to the health of the population. So, on to section 1, our healthcare data. What does it look like? I want to describe to you what gets included or written in your patient records when you see the doctor. So, our first port of call when we get sick is to go and visit the GP. If you've ever peered around the screen when your GP is typing up notes, you may have seen a screen that looks something like this. So let's find out how GPs record clinical information during consultations. So here's Tom. Tom has made an appointment to see his GP. In his GP notes is already recorded basic details like his name, his date of birth and his address. Tom sees Dr. Jones and he explains that he's been getting a bit overweight, he gets thirsty, he needs the toilet a lot and he feels tired. Tom says when Dr. Jones asks about his family history that his mother had diabetes. Dr. Jones decides to test Tom's blood sugar by doing a finger prick test and reading the blood measurement. She says his blood sugars are raised and that he needs to be followed up in the diabetes clinic. So what might Dr. Jones write in Tom's record at the end of this consultation? So here's an example. So you can see down on the left, there's demographic and contact details, which will always be the same for Tom. They'll come up each time. Then there's prevention data. Again, these are long-standing pieces of information, such as whether he smokes, if he has allergies, how much he drinks. And then there will be information captured for each consultation. So Dr. Jones can choose to capture clinical information about Tom in a hierarchically organised clinical coding system. In the GP system, this is called read codes. And Tom can also type out natural language free text clinic notes, which you can see here. As researchers, we can extract out clinical information captured in the codes pretty easily. But we can't usually extract out the information captured in free text. This is because of risks to patient privacy. You can see there might be a lot of information about Tom and his illness that we might miss as a result as researchers. Clinical codes in general practice, these Reed codes, which were invented by a Dr. Reed in the 1980s, cover a wide range of possible types of clinical information. GPs can capture routine screening and lifestyle codes. So that first one, OE, means on examination, pulse rate. Smoking, you can see there, they can capture tests being carried out and their results. Family history codes, symptoms, signs, and also diagnoses when processes to find out what's wrong with the patient have been completed. And then there's a lot of general codes as well. To patient's condition improved, seen in GP surgery. If you look back at Tom's record, he had one there, 8CB, had a chat to patient. These are quite commonly used by GPs who then capture the clinical information in the free text. It makes it quite difficult for us as researchers to interpret what happened in that consultation. So moving on from general practice, Tom doesn't only see his GP, he also gets a referral to the mental health trust because he's feeling depressed and sometimes he hears voices. He's assessed there by Ahmed, who's a mental health nurse. Ahmed asks him all about his background, his current symptoms and how they're affecting him day to day. And he suggests that Tom should see a psychiatrist and that he should have a referral for some types of therapy. And Ahmed types up these notes on Tom's consultation. You can see this looks quite different from the GP record. It's much more full of text. Mental health trusts rarely code a lot of clinical information, perhaps just the core diagnosis of what condition the patient's been diagnosed with. So you can see it's hard to extract meaningful information out of this wodge of text, much harder than it would be if it was codes. And we need quite specialised natural language processing approaches, text mining approaches to work with this kind of patient data. And then if Tom ends up going to hospital, well, it's hard to say how his data would be captured. Hospitals have a range of different patient record systems. There's no one universal system. They capture diagnoses and processes of care to secure payments from the government for the care that they've provided. And some of this is captured centrally in NHS Digital. One example of this is the critical care minimum data set, which is reported back, and it's part of what's called HES, so that's hospital episode statistics, which are statistics on every episode of care that's taken part in hospitals across the UK. This just includes basic elements such as who the patient was, how long they were admitted for, and what types of advanced care they received and for how long. But it doesn't include all the chart data, free text observations and lab results and things like that. If you want to access that kind of information for research, then you kind of have to go directly to the hospital and have an agreement directly with them. For example, King's College London might be able to have an agreement with Guy's and St Thomas's Hospital in London to have access to their intensive care data because of their close links. But down in Brighton, we probably wouldn't get access to that. Okay, so now we understand what type of data is being collected. Why might we want to use it for research? Obviously, the key and overriding purpose of this data collection is to provide good care to each individual who's seen in the health service. But secondary purposes are also important. These include research to understand more about disease risks and causes, improving diagnosis, perhaps with clinical decision support systems, developing new treatments, preventing disease, planning services, improving safety, and evaluating new policies. For example, regarding Tom, we could use data from Tom and patients like him to answer different types of questions about diabetes, such as whether diabetes could be identified earlier by looking at common symptoms in the GP patient record before diagnosis, or simple cause and effect questions like whether having diabetes makes patients at higher risk of breaking a bone or at higher risk of pancreatic cancer. And we could also look at, say, linked mental health and primary care records, so understanding how hearing voices might affect people's lives and the ability to work, or whether the physical health needs of people with hallucinations are being met in primary care. But before patient data is used by researchers, we need to do several things, because it's not possible to gain informed consent from each patient before using their data. Although we do have something called the National Data Opt-out, where you can register your dissent from your data being used. So it's an opt-out system in the UK. There are some key constraints, therefore, on the use of NHS data sets. Firstly, it has to be stripped of personal identifiers and made functionally anonymous, so that the risk of re-identifying a patient is absolutely minimal. And for extra protection, it's often stored in specially protected data safe havens, where only trusted users can have access. So a few words on anonymisation. There are different levels of stripping identifiers out of data. This diagram shows 3 possible layers. The first one where the data is identifiable, and the second one where it's de-identified. So just taking names, addresses, date of birth out, but leaving person-level sequences of events in that data that may be unique to each person. And therefore, if we have another data set about them, or perhaps a newspaper article or something, we could potentially re-identify somebody from that data set. But if we perturb or add noise or change things about the data, delete unique cases or aggregate data, it becomes properly anonymous. We wouldn't be able to re-identify people from it because there aren't any unique sequences of events anymore. So this is much more anonymous data, can be more openly released, it's less likely to be needed to be stored in a safe haven, but its uses for research diminish. There's less we can do with it. So there's this tension between really anonymising data and also keeping all the possibilities for research in it. And that's why data safe havens are often used. What does the public think about their data being used for these secondary purposes like research? Well, most people are fairly positive about it, but they hold 2 important values. The first one is that the research must be for public benefit. That is, it shouldn't be shared with companies just so they can make a bigger profit, or that patients can be exploited. And secondly, patient identities must be protected. So you can see here a couple of quotes from different focus groups. One about thinking that data sharing is for the greater good, and one about it being a social responsibility to help the next generation by sharing data from care that you've received. However, there's always a flip side to every argument, and we should consider that people can be concerned about harms that come from data sharing. People are worried about data breaches and re-identification leading to harms such as consequences for their employment, insurance or benefits, or community embarrassment or stigma as a result of the conditions they've got. And also they're worried about pharmaceutical or insurance companies having a profit motive and exploiting patients based on their medical records. So there's a couple of quotes here. I'm afraid one's covered up, but looking at worrying about who might be looking at the data, who's going to have access to it if it leaves the NHS. There's more on this topic at the excellent Understanding Patient Data initiative, which has a website. I've given you the link in this slide, and that's run by the Wellcome Trust. And I can also recommend, if you feel strongly about the use of patient data, to look into 2 advocacy groups. There's one that advocates for the more widespread use of data, that's called usemydata.org, and then there's one that urges caution around the use of patient data, which is called medconfidential.org. Okay, well, we're on to section 2, which is around using patient data at BSMS for the early detection of dementia. So we use primary care data that comes from GP surgeries, and we're trying to look at ways of improving dementia diagnosis rates in primary care. So currently, dementia diagnosis is often made at a time of crisis or when families are struggling to cope anymore with the care needs of the person living with dementia, and sometimes too late for the person with dementia to express their financial or care preferences and make plans about their illness. So if we could diagnose the disease earlier in its course, then patients might be able to try drug treatments to improve or maintain their function. They might be able to maximise their quality of life because they could inform themselves more about the condition and make plans and get the right resources in place for their family and wider carers. And clinical trials are likely to be looking for patients in the early stages when they come online. But at the moment there's a diagnosis gap. This means that around a third of patients who are living with dementia don't get a diagnosis recorded in their NHS patient records. What we thought was that we could tackle this using patient data. Here we have an imaginary timeline of a patient's clinical record in primary care in the 5 years before they got their dementia diagnosis. And we thought we could train algorithms on this data to look for signals that dementia was developing in that patient, and that this algorithm might then be able to flag that to the GP. So we found that there's probably two ways of looking at this problem. Firstly, using data earlier in the record that suggests that dementia symptoms are still unrecognised by the GP. There's no evidence in the record that the GP's noticed these symptoms. And we could combine various pieces of information to flag up to the GP that dementia might be developing, and they can take that forward in an appropriate way. And perhaps we can get diagnosis to happen earlier. And then secondly, we could use information in the record that shows the GP's already noticed that there are dementia symptoms developing, and we could flag that back to the GP. The idea being not that we can tell them anything they don't already know, but they might be able to improve their record keeping, which would enable better provision of care, better service planning, and more accurate prevalence rates. So we developed two models to detect dementia. The first one was around these patients where the symptoms were recognised by the GP, but there was no formal diagnosis in place. So we decided on a range of different pieces of information that we could find in the records that would indicate that the patient was recognised to have dementia, even though no label for dementia had been put on the record. We called these recognised but unlabelled patients. You can see this list of pieces of information here: memory loss codes, cognitive screening tests, referrals, specific medications, and we were also able to access keywords in the free text clinic notes for this particular study. We combined these in a random forest algorithm, and you can see here receiver operating characteristics, which indicates the accuracy of the models. With just the coded information, we were able to discriminate between dementia cases and control patients with around 90% accuracy, and when we added in the keywords from free text, this went up to 94%. So that was quite successful, but of course these pieces of information are so much more indicative of dementia than ones when the GP hasn't recorded or noticed those symptoms. So when we tried to find unrecognised dementia in the record, so earlier than the GP, so this is trying to develop an algorithm that could flag to the GP unrecognised cases. We found these different pieces of clinical information were the best indicators of dementia. Things like behaviour change, difficulty managing, self-neglect, they're all probably early symptoms of dementia. And perhaps that does mean the GP's noticed, but perhaps they haven't put two and two together yet. Our model had an area under the curve here, so an accuracy of about 74%. So better than chance, perhaps needs a little bit improvement before it can be rolled out in the clinic. That's a very brief overview of our project, AstroDem. If you're interested in that, you can look us up on our BSMS website. The URL is given here. But I won't go into any more detail on that because I want to talk to you now about NHS patient data use for the current pandemic, COVID-19. So we're in a pandemic, and the UK has a uniquely large universal coverage health system on which we can track the pandemic using patient data. We can use patient data to help the whole system, health and care together, work together. And data will be used for monitoring and responding to cases, tracking spread and transmission, planning resource management, and the provision of individual care. Data from the past used with mathematical models can help us to predict the future and make better plans for how systems should be prepared for new cases. So I want to tell you about 4 different ways that patient data is being used for COVID-19. This is not the only ways, but I think these are 4 interesting ways that data is already being used. First of all, we have the system of notifiable diseases. Serious infectious diseases that could cause an outbreak must be reported to Public Health England, and this has been the case for ever such a long time. They have a list of notifiable infectious diseases such as scarlet fever, measles, mumps, etc., to detect possible outbreaks of disease and to be able to do contact tracing and contain them as rapidly as possible. And of course, COVID-19 is now on this list. And this means that all cases of COVID-19, either diagnosed by a test or suspected by a doctor, must be reported to Public Health England. And of course, deaths with COVID-19 as a possible factor will also be recorded and collated by the Office of National Statistics. Secondly, another way that patient data is being used is to create lists of people who are especially vulnerable to the disease, who need shielding from it. So NHS Digital has run an algorithm through multiple sources of patient data to work out who needs this shielding. They developed a clinical algorithm, and it was run through hospital episode statistics, primary care data, personal demographics, and maternity services data set, so that patients with severe lung diseases or who are on immunosuppressive drugs or have certain types of cancer or cancer therapies can be identified. And then they are all sent a letter to advise them not to leave their home, and I believe many of them are followed up with regular text messages. The methodology for how that was run is transparent and openly available. I've given the URL at the bottom of the screen there. A third usage is for research on who might particularly be at risk. We're very fortunate in our country to have an amazing resource called the UK Biobank. It contains biological samples from 500,000 volunteers who've donated biological samples, including their genetic data, to this biobank. And results of COVID-19 tests for participants in the biobank are being supplied to that biobank to be linked to their genetic data and will be made available for research. Also going in is other patient data such as GP data on a monthly basis, the hospital episode statistics, and some intensive care data. And the reason for this is to create a huge linked data set in which the relevance of genetic factors to severity and outcomes of COVID-19 can be assessed, because we've seen that some people get a very mild disease and others get a very severe disease, and it's not clear whether perhaps genetic factors might influence who's particularly susceptible to the severe form of the disease. It will also allow researchers to assess the impact of other diseases on outcomes of COVID-19. We call these comorbidities. So which particular other conditions that people have make people very susceptible to a severe form of the disease. And then lastly, I want to talk about mobile phone tracking data. So this is not about data collected within the NHS, but will collect data from patients. The NHS is currently developing a contact tracing app that they will encourage people to download on their phones, and it will collect data about people's symptoms that they will input themselves, and it will track their location. And then the idea is that when a case is identified, people who were in a similar location at a similar time to that patient could be alerted that a case was in their area, and then they can also go and get tested. And it will enable the NHS to track where the virus is spreading. The thing is that 80% of current smartphone users would need to use it for it to be effective, and of course testing and contact tracing would need to go ahead at the same time. But it's clear that with COVID-19, public health contact tracing from traditional methods is too slow for this disease. The problem is, of course, a lot of transmissions occur asymptomatic patients, and so we need something that is really real time so that people can be alerted that they may have been exposed. So what is happening at the moment to enable real-time NHS data use? Well, NHS England is building a data platform so that we can see how the disease is spreading, and they'll be creating a range of dashboards that show live NHS 111 call data, COVID-19 test results reported by Public Health England, bed occupancy rates in different hospitals, waiting times and capacity at A&E, and lengths of stay for COVID patients. These will give a live view of metrics needed to track and understand the current spread of the crisis and the capacity in the healthcare system. The aim from NHS England is to make the code and the data open source wherever they can, but of course protecting the privacy and confidentiality of individuals. One of these dashboards is already live on NHS Digital, so this is the 111 online assessment app, where people put in their symptoms to see whether it's likely if they've got COVID or not. So they display this by location and by date, so we can track online how many people have completed that app and how many positive assessments have been made. I'm always interested in the ethics and governance around patient data, and I wonder how the NHS has been able to mobilise patient data so quickly for this pandemic, when it often takes researchers years to secure access to patient data. So obviously passing emergency legislation helps. Part of that is that health and care organisations have been notified that they have to share information to support efforts against COVID-19. But you may find it interesting that GDPR, which is the Data Protection Act from 2018, has exceptions to data processing laws for tasks in the public interest. And these exceptions are called in for this type of public health event. However, it should be noticed that NHS England states that GDPR principles will still be followed, for example, data minimisation, and only using data for this particular task in the public interest. I've mentioned earlier the national data opt-out, so that's individuals' possibility to opt out of their data being used, and this again does not apply when there's an overriding task in the public interest. Of note, some data has been shared with supermarkets around patients being vulnerable. So, for example, supermarkets have made lists of at-risk individuals so that they can be prioritised for food deliveries. So I'm assuming that this has been enabled under the task in the public interest override in GDPR. But I'm a great believer in core principles of integrity, transparency and trustworthiness when we're using patient data. And so I would say these principles should still be followed, and the Understanding Patient Data Initiative is also advocating for these, and they've written a blog which I've linked to at the bottom. So I would say all data sharing must have a clear public benefit. There should be sunset clauses in any new data sharing agreements so that it's time bound by the pandemic. And we should be aware of social and economic inequalities, especially when we start to rely on digital technology for the delivery of healthcare, for example, video consultations with GPs and contract tracing to enable people to get tested and self-isolate. Those who have the poorest access to digital technology are also likely to have the worst health outcomes, and we should ensure that these inequalities don't become more entrenched. We should ensure transparency as data practices change and consider how public trust can be ensured. So that's the end of my talk on public data in the COVID era, and I hope that you'll have questions for me in the Q&A session. Thank you very much.